My name is John McIntyre. It's my great pleasure to welcome you here on a very stormy Auckland night to Auckland War Memorial Museum for what is the first public gathering since COVID lockdown in the museum, and for such an important debate about a subject that we need to vote on at the end of the year. So my short mihi in my tried to pronounce Māori was just acknowledging Ranganui above, Papa Tuanuki below, the people in the life in between, and greetings to the guests gathered here tonight. Firstly, to the curator, to whom all things belong, to the dead, go, to the house standing here and the land outside, greetings. And lastly, greetings to you all supporting this kaupapa tonight. So tonight, we have a bit of a hybrid engagement. Unfortunately, one of the main directors of the study, Professor Richie Poulton, was unable to travel up from Dunedin. He was unwell. So we have a hybrid discussion tonight with Dr. Joseph Boden, who's the other co-author of the paper, and a moderator who's off-site as well, and on Zoom, Dr. Moana Theodore, who's also a co-author of the study. But in essence, in September, New Zealanders will vote on whether to endorse the cannabis legislation and control bill, which would make possession and recreational use of cannabis legal for people aged 20 and older within their own homes and on licensed premises. So essentially the question is, you've got two choices, yes or no. That's it, which is a little bit disappointing from the government to just only restrict us to those two choices. So the proposed bill sets out a way for the government to control and regulate cannabis. The bill's main purpose is to reduce cannabis-related harm to individuals, families, whānau and communities. Interestingly, medicinal cannabis and hemp will not be affected by the outcome of the referendum, as they are already legal and they are not part of the bill, so they can still be prescribed on a legal basis. So without further ado, I will pass over to Professor Joseph Boden and Dr. Moana Theodore, who will take you through the study, the longitudinal study, and between the two of them we'll be asking questions of each other. Thank you.
Tēnā koutou katoa. Thank you very much for coming out tonight. And I'm actually just going to turn over to Moana, who is going to seem like a disembodied voice to you. So we do apologize for the nature of the presentation, but I'll let Moana go first. Are you there, Moana? Says she's talking.
Kia ora, Joe. Can you hear me now?
Yes, we can.
Tēnā koutou katoa. I'm not sure if you can see me there live in person. Hopefully you can see me on Zoom. Ko rere Moana Theodore tōku ingoa. Kia ora everyone, my name's Moana Theodore, and I'm the co-director of the National Centre for Lifecourse Research at the University of Otago, which I co-direct with Professor Richie Poulton. We're based in Auckland, Dunedin, where I am currently. And I'm also a member of the Council of the Royal Society Te Aparangi, and it's my absolute pleasure to be invited to moderate tonight's panel discussion about cannabis use in the September referendum. And as mentioned already, we're going to be using a bit of a hybrid approach. We're all sort of getting used to using Zoom and these sorts of online platforms in our everyday lives. So today, as mentioned, is going to be a live and a Zoom audience. And so welcome to everyone that's tuning in from around the motu, and also those that are live there in Auckland. As mentioned, unfortunately, Professor Richie Poulton isn't able to join us tonight, and he is sad to not be there. So I'll do my very best to fill in for him. Obviously, I'm not as good looking as him, but I'll be the one that will be telling you about the Dunedin study, which Richie has directed for 2 decades. And the research that study has done on cannabis, particularly in the lead up to the referendum. In the live audience, as you know, we have our other speaker, Professor Joseph Boden. Joe directs the Christchurch Health and Development Study, and he is a member of the Prime Minister's Chief Science Advisors expert panel on cannabis. He's joining us live from the Auckland Museum, and it's important to note that this event is being hosted by the Museum Trust, the Auckland Museum Institute, and the Auckland branch of the Royal Society Te Ao Parangi. And we thank you very much for inviting us to speak tonight on this important topic and for hosting this event. And thank you very much, John, for your warm welcome this evening. Tēnā koe. So the format for tonight's panel discussion will be that Joe and I will talk a little bit about the Dunedin and Christchurch studies, and we're doing this in order to provide some context about the studies before we get into talking a bit more about the study's findings on cannabis use. And then we'll be having a question and answer session where I will ask Joe some of the key questions that we are often asked, that people often ask us about cannabis and the findings from the studies. Unfortunately, we won't be able to take questions tonight. But when the talk finishes, what we're going to do is we're going to be providing some information about our new website. It was launched yesterday, and it's a place where people can go check out some of our studies findings in an easy to understand and accessible way. So we'll be showing you that at the end of our presentation. Also, I understand for those of you that are there in Auckland at the museum that Joe will be staying on afterwards for a little while. So if individuals want to come and have a talk to him, he'll be there to do that. So for the people on Zoom, you may have some trouble. We're not sure seeing the PowerPoints from tonight's talks. So what we'll try to do is we'll try to also look to make them available on the Dunedin Study website in the next few days. And also Joe and I will do our very best to talk through them as we're going. Okay, so I do think what might help in terms of the connections, if those are on Zoom, if you'd like to switch your videos off, that might work out better. Okay, so if I could have the first slide, please. Thank you. So I'm going to put my glasses on too. In September, as John has already mentioned, New Zealanders will get a chance to vote either yes or no to legalising the personal use of cannabis. Next slide, please. So in the lead up to the referendum, actually I can take the glasses, a number of researchers, including ourselves, have been working to provide information to help support an evidence-informed approach to help New Zealanders when they enter into the voting booths in September, so that people can make informed decisions for themselves and their whānau about whether they wish to vote yes or no to legalising cannabis. And tonight we're going to talk about the work of two of New Zealand's internationally renowned longitudinal or lifecourse studies that are based at the University of Otago. These two studies have followed more than 2,000 people from birth into their mid to late 40s. And the Dunedin and Christchurch studies have been described as two of the most detailed sources of information in the world on the natural history of cannabis use, including the life course consequences of cannabis use and misuse. Next slide, please. Thank you. Okay, so a lot of people have heard about the Dunedin study, but for those of you who might not have or don't know too much about it, it's an ongoing, long-term longitudinal study of health and development and well-being of a general sample, approximately 1,000 New Zealanders. They were all born in Dunedin between April 1972 and March 1973. And as you can see from the slide, they've participated in the study at multiple times throughout their lives. And most recently, they were seen at age 45 years, where nearly 94% of the living cohort were seen. And so while it's not the biggest or the longest study of its kind, having these types of high retention rates is important, because what it means is that people who would normally in these types of studies drop out or be hard to locate or reassess actually continue to participate in the study. And these people are usually the ones that might suffer from more adversities or more of life's difficulties. So, for example, maybe having poorer mental or physical health, moving around a lot. And so the high retention rates of the Dunedin study mean that the study helps to capture a full range of people's life experiences. Next slide, please. Now, if Richie were here, he'd say at this stage in the talk that people usually think, well, those high retention rates are probably because most of the study members have stayed in Dunedin all their lives and they don't get out too much. But if you can see the screen, these were the locations of the study members at age 45 years. And current travel restrictions aside, you'll see that many of our study members actually live overseas, about a third. If I could have the next slide, please. Thank you. Unsurprisingly, given the long name of the Dunedin study, which is the Dunedin Multidisciplinary Health and Development Study, the information that's been collected over time with the study members and their whānau has been multidisciplinary in nature. And what we mean by that is that we collect a lot of information about a range of health and development outcomes, which you can see if you can see this slide. So, for example, things like oral health, respiratory health, antisocial behaviour, employment, cognition, mental health. And if I could have the next slide too, please. Again, this slide just gives more information about the things that we collect and sort of shows you the breadth and depth of the study's research, which includes measures of physical and mental health. And I think it's fair to say that these assessments have been getting more and more complex over time through the use of new technologies, most recently brain imaging at 45, to continue to look at the study members' health and well-being. Next slide, please. Thank you. Of course, the real heroes of this study are the anonymous study members and their whānau who continue to turn up and support the study with the hope that their contributions, their time, can help to improve the lives of other New Zealanders and people internationally. And so it's really important for us as researchers to share these findings as we're doing tonight. Next slide, please. Okay, now I'm going to hand back over to Joe in the Auckland audience to tell you a little bit about the Christchurch study. Over to you, Joe.
Thank you, Moana. Yes, my name is Joe Boden. I'm a professor in psychological medicine at the University of Otago, the Christchurch campus, and I'm the director of the Christchurch Health and Development Study. I've actually been a staff member on the study for 15 years, and I was appointed director last August in the impending retirement of our previous director. Next slide, please. So just a bit about who we are. The Christchurch Health and Development Study was originally conceived as a study of single parents. Professor Fred Shannon, who's the foundation professor of pediatrics at Christchurch Hospital, wanted to study the outcomes for children who had less well-off upbringings, essentially, and he was advised that he shouldn't do a study of single parenthood. He should do a longitudinal study with a community with a community sample. So. In 1977, he hired Professor David Ferguson to run the study, and during the period from 15th of April to the 15th of August 1977, 1,265 babies were enrolled in the study, and that was 97% of births during that period. You may remember that back in the day, new mothers stayed in the hospital for much longer than they did now. So typically we say is because they were in the hospital and bored that they agreed to do it. So they have been studied first at birth all the way to age 40, which was 3 years ago. And they were seen annually to age 16, then at 18, 21, 25, 30, 35, and 40 years. And our retention hasn't been quite as good as the Dunedin study, but we're still seeing about 75% of the surviving cohort at age 40. As you might imagine, this has generated a huge amount of data. So early on, we interviewed parents, eventually teachers. When cohort members were 7 years old, we began interviewing them. At times we have interviewed partners, and we've collected official record data, health records, and justice records thus far. And so, as you might imagine, there's a large amount of data collected on health and psychosocial outcomes. We tend to be less health-focused and more socially focused than the Dunedin study, but many similarities between the two, and particularly in terms of measurement. But we also study the social, family, and we have data on social, family, individual, and demographic factors for the purposes of trying to build causal models of things that happen during the life course. Next slide, please. Right, so just a history of the assessment of cannabis use in the CHDS. When cohort members were 13, we asked them, have you ever tried cannabis? And 5 people said they had. And also at 14 and 15, but from age 16, we started assessing the frequency with which people use cannabis and any symptoms that they might have had of, what's this DSM there, which is the Diagnostic and Statistical Manual of Mental Disorders, cannabis dependence. So at the current time and also for the past 12 months. And from age 18 onward, we assess the frequency, current, and again for each 12-month period, and symptoms of cannabis dependence since the previous assessment. So basically, we're asking them, how often do you use cannabis? Do you have any of these problems? And the frequency data range from I don't use it at all to I use it several times a day. At age 40, we assess the co-use of cannabis and tobacco, so putting them together, attitudes toward cannabis and cannabis law change, which we've just published a paper in the New Zealand Medical Journal on, and whether participants had used cannabis medicinally. Next slide, please. So, like the Dunedin study, we have a wide range of things that we're interested in studying. I've spent most of my time in the past couple of years talking about cannabis, but obviously we've done many other things over the course of the history of the study. We've studied respiratory illness in children, swimming pool safety, exposure to lead and outcomes from that, childhood behavior disorders, mental health, substance use, and now moving into middle adulthood, very concerned with things like social and economic outcomes. And so now, at 40, we're still interested in things like mental health and psychosocial outcomes, substance use and substance use disorders, economic outcomes, but also parenthood and parenting. The long-term consequences of abuse exposure in childhood is one of our main interests. But also, we were in the unusual position of being a longitudinal study set in a city that had a major disaster, where half the people in our study were exposed to the disaster and the other half weren't, because they live outside of Christchurch. And so one of the main themes of the last several years has been the consequences of exposure to the Canterbury earthquakes. Right, so I think that's it for my part of the talking, and Moana's going to start asking me questions. Moana. I can just extemporize if you want.
Kia ora, Joe. It just takes a little while to come off mute. I think that's everyone's this experience over the last period of being stuck on mute while trying to talk. So I'm back. Can you hear me okay?
Yep.
Okay, so I think what that sort of shows is not only just the breadth and depth of the individual studies, the Christchurch and Dunedin studies, but why we've wanted to do more work together to sort of align some of the findings and bring them together to help inform around topics like cannabis that are of importance to New Zealanders. So without further ado, Joe and I are now going to do a question and answer where I'm going to be asking them some questions about the two studies' findings that we hope will inform you ahead of the cannabis referendum. So Joe, my first question is that people are sometimes surprised at just how many people the studies have found have actually tried cannabis at least once in their lifetime. Are you able to tell us a little bit about how many people have ever tried cannabis, and also those that might use it more regularly?
Yes, I can. So you will have heard in all of this debate probably the famous 80% figure, and that figure comes from both of our studies that find that over the life course, about 80% of the members of each cohort have reported using cannabis on at least one occasion. Now, if 80% of people do something, that means that behavior is normal. Right? It is a normative behavior. It is a normative behavior to use cannabis at least once if you grow up in New Zealand. Now, of course, the number of people who use regularly, and by that I mean at least weekly at some point in their lives, but it could be more often than that, that number is much smaller. So that number is about 35% in both studies. And the group, if you look more closely, there are people who use more regularly than that. So for example, daily users, they constitute a very, very small number of people in each study. So really in the single digit percentages, running about 5% at any given assessment. So very unusual. Now, you have to keep in mind that this was an historic period where cannabis use rates were very high. And unfortunately, I can't give this talk without a lot of puns, so I apologize. Historically, rates of use were very high. And as you might guess, the level of use in the population is not really 80%. It's actually quite a bit lower than that. Some estimates say it's closer to 50%, but that's simply because of variations in rates of use in different cohorts of people who were born at different times. So less common in much older cohorts, and again less common in younger cohorts, but we know that young people are using considerably less cannabis than young people did when I was their age or these cohorts were their age. What else did you want to ask me about that?
So I think that's an interesting point if we think about the Dunedin and Christchurch study members, because they are sort of in their 40s and they are the parents that are going to be voting in the cannabis referendum. That particular generation, Generation X, that had quite a high experience with cannabis use and maybe some of its issues. And am I right in thinking that those rates sort of dropped over time for the study members regardless? So fewer people were using cannabis over time?
Yes, that's right. So the peak for the CHDS was at the age 21 assessment. So that was the most amount of cannabis that was being consumed. And there's one thing that actually predicts desistance from any substance use, but particularly drug use, and that's the onset of parenthood. Right. So we've shown in a couple of papers that this is the thing that when it happens, people stop using drugs essentially. And so over the last 10 years of the life of the CHDS cohort has been the period at which most people in the cohort have become parents, because we have a very late age of first parenthood.
And then there is also just a small percentage that have what we consider cannabis dependence, so issues with using cannabis that affect their work, that affect their lives, that affect their whānau. That's correct.
That's right.
Right?
And
Okay.
about 15, we have a lifetime prevalence thus far of about 15% for cannabis dependence, or what's now called cannabis use disorder. But again, that just means if you've ever met criteria for it. At this age, there are many fewer people who meet criteria for that.
Okay. And so we've talked a little bit about parents, and I guess so my second key area that I'm going to ask you about, which is quite a complex subject. One of the concerns that we often hear from parents and from whānau is in relation to the legalization of cannabis is about the effects that cannabis may have on young people, may have on their children. And so in terms of what both the studies have found, they have been able to shed some light on how cannabis use may affect mental health in young people. For example, conditions like psychosis. Now, I know, Joe, this is a particular topic that you could spend a number of talks talking about, but I'm wondering if you'd be able to give our audience a little bit of information about what the studies have found in this area, and perhaps particularly in relation to early adolescent use and the regular or cumulative use of cannabis?
Oh, I'd be happy to. So in both studies, we've looked at rates of cannabis use, but we've also looked at whether there's an association between rates of cannabis use and issues around psychosis. So in the Dunedin study, it was meeting criteria for a psychotic illness. And in the Christchurch study, it was having symptoms of psychosis. And what we found is that if you were a daily cannabis user, at some point before the age of 25, your risks of reporting symptoms of psychosis were about 80% greater than they would be otherwise if you were a daily user. Which seems large, but you have to remember a few things. The risk of reporting these psychotic symptoms is pretty low in the population, so it seems like a large increase in risk. And it pertains probably only to a certain segment of the population. There's an important paper that came out of the Dunedin study that showed that it was people who have a particular variant of the COMT gene, which regulates neurotransmitter activity in the brain. And there are about 25% of the people in the population who have this particular genetic variant. And they were the ones who were at risk of developing psychotic illness, whereas people who didn't have that genetic variant actually weren't. So what that really means is that we're talking about a small group of people who were daily users at a young age, right? So mainly in late adolescence or early adulthood, who were daily users, but who also had a genetic variant that put them at particular risk. And that's actually, the size of that population is really only about 1/16 of the population is what we're talking about in terms of these two events coinciding. So the risk is relatively low in terms of because it's very specific to a population. Some people ask, could you theoretically test someone to see if they had this genetic variant? And theoretically, if you were able to do the genetic test, yes, you could. You could identify whether you were at increased risk or not. Now, one other thing that I've actually had a student working on this project, because if you've paid attention to the news of the last while, there's certain sets of advertisement going on that say, well, if people are using cannabis, it's going to make them crazy, and then they're going to be violent, right? So you probably have seen some variation on this. But I wanted to look at it a bit more carefully in terms of the kinds of symptoms that people were reporting, right? So it's true that in our study, people are reporting higher levels of symptoms of psychosis, but symptoms of psychosis range from very mild to quite severe. So a very mild one is endorsing an item, for example, that says, I sometimes have thoughts that other people do not share, right? Which you think, as an adolescent, that's probably a pretty common occurrence, right? And all the way up to, I hear voices in my head telling me what to do, right? Now, you could theorize that if it was increasing psychotic illness, if this really was a strong causal thing, that the symptom profiles of people who are regular cannabis users would look different from the people who weren't cannabis users, right? Except I've just done an analysis that shows that they're exactly the same. They report the same common garden variety symptoms, like I sometimes have thoughts that other people do not share, and they very rarely report the severe symptoms, right? Symptom profiles do not differ at all whether you are a regular user or not regular user. You just report more of them. So I think that's actually, we're hoping to publish that shortly, but it won't be in time for the referendum. There is also, I should mention, Moana, there is a weakish link between cannabis and the use of cannabis and depression. It's so weak that it took us 4 studies combined, so our study and 3 Australian studies, to combine and use the data from all 4, so about 4,500 people, to be able to even detect it. And we can't tell what direction it goes in, whether cannabis makes you depressed or whether you might be depressed and you use cannabis to alleviate that. It could be either.
So Joe, I suppose in summarizing those points for, I guess, the viewers at home and the viewers in the audience, the idea in and around, I guess, that regular and very early use in early adolescence, particularly for individuals who might have a family history of some of these conditions, is a key message there in terms of that cannabis can have its harms, particularly for young people, particularly for regular users and those that have a family history.
That's exactly right. It looks like the primary age range for the risk is earlier and heavier use. So what you really want to do is restrict use in that 15 to 8, particularly that 15 to 18 age group where use is really starting to pick up. But that's when their brains are most vulnerable because of the development of the cannabinoid receptors in the brain, which reach their set point, as it were, around age 25.
And I think that's been where the importance of the Dunedin and Christchurch study findings have been, in the sense that they've both been able to follow, these people over time, especially when they were in their youth. And I think an important thing to note for the audience is that in regards to young people, the draft legislation, which is available online if you go to the New Zealand government website, has some, so that's if cannabis is legalised, currently states that for a person under age 20 who's found in possession of cannabis, they would be receiving a health-based response, such as an education session. So it wouldn't be legal for, have I got that correct, Joe? It wouldn't be legal for someone under the age of 20 to be possessing cannabis, but if they were found in possession, they would receive a health-based response, such as an education session, social health service, or they would have to pay a small fee or fine, but it wouldn't lead to conviction.
Yes, that's correct.
Yeah. And also the draft legislation says that it would be illegal to supply or sell cannabis to a person under the age of 20. So the draft legislation takes into account the importance of protecting young people in and around cannabis use. Is that fair to say, Joe?
Yes, that is correct. So it'll be the same sort of enforcement provision that exists now for shops that sell either alcohol or tobacco to people who are underage. So get quite a hefty fine, the possibility of jail time, as it's written now in the draft bill. We say draft bill because even if it passes, they still have to do the usual parliamentary debate over it. But also, and the person selling it would end up losing their license for at least temporarily, but possibly permanently, depending on the number of offences, I suppose.
Okay, and as I said, you can go online and read that. It's quite I don't remember how many pages, it's more than 100, but it's online at the New Zealand government website, and there's also summary as well. And it does, on that front page, talk about, in particular, people under 20 and what if people vote yes to legalise, then what that draft legislation might look like, which takes into account those age issues. So I'm going to ask you some questions, kind of leads on nicely to the fact that the studies have looked at convictions. But before I do, I know Richie will say I would be remiss not to say, and given that the Dunedin study has focused on physical health, that there's also been some studies from the Dunedin study that shows that the regular use of cannabis has been associated with some physical health conditions and physical health outcomes as well. For example, gum disease, so dental health, and also lung function as well. And that's something that people at the very end, in fact, if we could have the next slide, please, we could probably have that up on the screen for the rest of the talk, so that people can go onto this website, cannabisreferendum.co.nz, and it'll have all the information that we're talking about from today's talk, and it will also give you some information on those physical health outcomes. So we can just leave that up on the screen. But that's also important to note. So both the studies have looked at mental health they've also looked at physical health, especially now that the study members are aging as well, so in their mid-40s, and we'll follow them over time. Okay, so we've talked about some of the health issues, and I think that's really important for us to focus on, because I think that's where the Dunedin and Christchurch studies and these longitudinal studies have really been able to provide some information to help inform the public in and around cannabis use and its potential harms. One of the things, so the findings and advice that's come out of both studies, Joe, has been that the use of cannabis should be viewed as a health issue and not a criminal issue. That is an approach that would enable young people in particular to have access to education about the effects of cannabis, and also provide access to early prevention, intervention and treatment for users who may be dependent. We've talked about that 15%, or who may struggle with its use. And by doing so, by providing those services without stigma or barriers, it could help those that are currently wanting to seek help or information as well. The Dunedin and the Christchurch studies have written a number of papers about cannabis convictions, including the findings of racial discrimination in the way that cannabis laws have been administered. Joe, are you able to tell the audience a little bit about the research that has been done in relation to cannabis convictions, particularly when the study members were young people, and also the racial bias that was found in relation to how the cannabis laws have been applied, particularly for young Māori?
Of course. So the first thing to note really is that we had for most of the term of the existence of this study, we had a regime whereby cannabis was prohibited. And yet I've already told you that 80% of the cohort had accessed it at least once. So that prohibition clearly doesn't stop access. But what we looked at when the cohort members were 21 years old is whether they had been arrested or convicted of a cannabis-related offense. And so the question being, does having the force of the law applied to you change your behavior? And the answer was no, not at all. So 95% of the people who received a conviction for a cannabis-related offense either continued on using cannabis or increased their use of cannabis afterwards. Right? So the law, prohibition doesn't actually keep it out of your hands. Having the law applied to you doesn't actually stop you. And the third part of this is that the CHDS cohort has about 13% Māori participants in it. A bit lower than the national average, but representative of Christchurch at the time. And what we found is that Māori cohort members were, and this is after taking into account differences in rates of use and related things, Māori cohort members were 3 times more likely to be arrested or convicted of a cannabis offense than non-Māori cohort members. Right? That's after basically equalizing the rates of use in each part of the cohort, which clearly shows that the law is applied in a racially biased manner, right? And this seems like the perfect time to be in history to be talking about this right now. So the law isn't deterring anyone. It doesn't deter you when it is applied, when its force is applied to you, and it's being applied in a racially biased manner. So the law is clearly not fit for purpose. Right? It's not doing what it should be doing. And my colleague Kylie Quince, who's a lawyer, said that actually brings the law, or the idea of the law, into disrepute when you have laws that do not serve their intended purpose and actually cause a great deal of harm to individuals who receive a conviction, because it stops you being able to travel and go places and having certain jobs and all of these things. So, for example, a colleague of ours, didn't know till 24 hours whether he was going to be able to enter the United States, for example, because he had a conviction in the past.
And it's great mentioning the work of Associate Professor Kylie Quince. I know you're working with her and some other researchers as well, Dr. Hinemua Elder, on the Chief Science Advisors Expert panel. So we'll be interested in finding out when some of that information will be coming out. That will be coming out before the referendum?
7th of July.
Okay, so
I'm looking at our writer right now.
You're busy working on that, are you? Okay, so without overwhelming the audience, that will also be coming out, and that will, so we're talking quite a bit about the health, because that's what the Dunedin and Christchurch studies have looked at, but that will cover the range of, I guess, a range of areas, including convictions and other things as well. Is that right, Joe?
Yes, that's correct, and it will be set out in sort of a frequently asked questions with drop-down menus online and things like that. So quite easy to navigate and full of hopefully interesting content that we've been able to supply.
Right. So there is a lot of stuff coming out, and seeing we are, coming to you live from, in Auckland from being supported by the Auckland branch of the Royal Society, Te Aparangi, it's also important to note that they have also done some work and published in relation to the health impacts of the impacts of cannabis as well. So, and that would already be on their website, especially for you in the Auckland audience who are part of that. So that's the Royal Society. So, one of the things that we talk about at the studies is that the harms of cannabis, as you say, Joe, affect users whether or not cannabis is legal or illegal, and that drug prosecutions or convictions don't actually stop people from using it. You said nearly 95% of those arrested or convicted continue to use it. And the other thing we know is that prosecutions, having a criminal history, being arrested or convicted, can also negatively impact on people's health and well-being, on their future prospects, including getting employment, and as Joe's pointed out, travelling the world, and also on their whānau, for example, family separation. So I think that's something we often discuss at our studies. So I think I'm going to move on to the final area that we're going to talk about now, which is probably another one of those really commonly asked questions that we get at the study, and that is about whether cannabis is a gateway drug to harder drugs. Joe, are you able to tell us a little bit about what the studies have found about that, given that they've been able to look at the lifecourse use of cannabis over time?
Yes, I can. You'll typically see this position being caricatured in some way, as though using cannabis will inexorably draw you into the web of drug use, and you'll end up dying in an alley somewhere. Whilst that is not the case, that is clearly not the case, we did find in our study that people who used cannabis more heavily and at earlier ages were more likely to go on to use other illicit drugs than people who didn't use cannabis, and there was a particular age gradient. So very powerful if you were a regular cannabis user when you were 15, 18, but that started to wear off. And even when we tried to statistically control for things that could predict both cannabis use and other illicit drug use, we weren't able to remove this association. So it's slightly perplexing in a way, but if you think about it in terms of the social milieu of a cannabis user, particularly a regular user, most people are introduced to it by their friends or by a relative of same age and things like that. But if you go on to be a regular user, you actually have to interact with drug dealers, or know someone who interacts with drug dealers. And the thing about drug dealers, well, there's several things about them. One is they don't check your ID to see how old you are. Two, they don't label their products. So product safety, folks. And three, they frequently have other things to sell besides cannabis. And so it's quite possible that what drives this gateway, if it does exist, is simply social opportunities to use other drugs. Now, there was a study from the Netherlands that came out in 2003, and as you may or may not know, in the Netherlands, cannabis has been decriminalized for personal use since 1974. right? And it is sold in premises called coffee shops. And you can use it there in the coffee shop, or you can take it home and use it yourself in your home. And they did the exact similar study, slightly different methods, but a very similar study looking at the links between cannabis use and in this case, cocaine use, which is quite common on the European continent, not in New Zealand, but common there. And they found no link, with the idea being that if you're a cannabis user in the Netherlands, you don't have to go to a drug dealer. You just go to the coffee house, and that's all they sell you. They don't have any other drugs to sell you, just that one. So that's some bits of evidence around. It may very well put people in a social location or milieu whereby they're more likely to encounter other illicit drugs. But we would think that if this social hypothesis is true, then the legalization of cannabis would actually reduce this gateway link. It would sever it.
Yeah. And so I suppose, and I'm not just saying this because I'm a researcher, that one of the things I think we need to think about in terms of if cannabis is legalised, if New Zealanders do go to the polls and they do decide to vote yes, and then the draft legislation comes through, is the need for the ongoing monitoring of the impacts that might have, both in terms of rangatahi, in terms of young people. We've talked about them in particular. I think they're could be a particularly vulnerable group. So making sure that we are monitoring what happens in terms of rates there. As Joe mentioned earlier on, and correct me if I'm wrong, Joe, that the rates from studies like the youth surveys have shown that younger people may actually be using less than their Generation X parents. So the rates may be potentially may be dropping. So it's important that we keep an eye on that in terms of the researchers. Is that correct, Joe?
Yes, that's correct. There was a recent study by Jude Ball at Otago and showed that up to between 2000 and 2012, rates of cannabis use would just dropped across the board. And the decline in use was particularly strong for Māori, such that rates for Māori youth by 2012 were actually very similar to non-Māori. And so really, as I said at the outset, these cohorts were born at a time and became adolescents and adults at a time when cannabis use was more common and seems to be decreasing now over time. But I couldn't agree more with Moana's point that we actually really need to monitor this very carefully. And we need to be better about our data collection at the population level, I think, than we are now. Now, the bill actually allows for the creation of not only a cannabis authority who will oversee the implementation of the laws and the creation of all of the structures and things that need to happen, but will also have an advisory panel. And I believe that the advisory panel is going to be tasked with ensuring that there's ongoing research activity and monitoring around these things.
And I think that's again, not just saying that because we're researchers, but I think that's an important point. And also the other thing that you did, Joe, nicely was you talked about the international experience. And I think as researchers and people that are thinking about the cannabis use and the cannabis referendum, one of the interesting things most recently was some findings from both Canada and the United States, which suggest in places where you can people can use cannabis that's been decriminalised or legalised. I'm not sure which of the two. I guess it depends on the particular area. Is that right, Joe, in terms of Canada and the US? But
that's right.
The rates of use amongst young people didn't increase.
No, they haven't. There was a little bit of evidence that they did in Washington State, but it was a small increase. It was offset by a larger decrease in Colorado, which were the first two U.S. states to legalize it. But notably, Canada legalized cannabis for personal use in October 2018, not through a referendum. So they actually did it through passing laws. Notable that prior to the law change, only 35% of the population who were polled said that they were in favor of it. After about a year later, they polled them again, and 70% of the population was in favor of it. But what they found is that in 2018, the age group, they were reporting that the age group 15 to 17 years old had a rate of cannabis use in the past 12 months of about 19%. Right? In the calendar year 2019, that dropped to 10%. And only half of their cannabis economy has moved from the black market to the licit market, has moved over from illicit to licit. So what that suggests is that there's probably some deterrence in terms of young people and keeping it out of their hands in terms of if it is sold in legal establishments where ID has to be checked, and of course the proprietors know that people are going to be monitoring them to make sure that they're complying with the law. So it would suggest that this is improved significantly. 9% is a big drop and it's certainly out of a margin of error. We'll say that.
Yeah, goodness. So I think we're nearly on time, but I just want to up on screen and hopefully on Zoom you'll be able to see the new website that we launched yesterday in relation to the cannabis referendum, cannabisreferendum.co.nz. It is easy to navigate and access information. It will have all the information that we've talked about tonight and in more detail and in particular areas that you might be particularly interested in. And it's based on the paper that was on one of the earlier slides that we showed around cannabis, the cannabis referendum, which we wrote as a combination between the two, the Christchurch and Dunedin studies. So I'd just like to say thank you to everyone that joined us live on Zoom. This was an experiment of sorts, so I'd like to say that I think the Auckland Museum Institute and the Auckland branch of the Royal Society Te Aoparanga have been very brave with this hybrid approach, and hopefully people have been able to hear okay and have been able to follow along in the live audience as well. Obviously this is an area that we'll continue to do work in. It's an area we're passionate about, and I'll have to say for myself, and I know I've had these conversations with both Joe and Richie, not only as researchers but also as parents, and we all have teenagers ourselves, so part of the reason I think we all got very interested in this area as well was to think about what it means for ourselves and our whānau, so we were informed ahead of the vote, and also sharing that important information from all of those study members that have given their time over those years to provide information that can help us to be informed about what we would like to do for ourselves and our whānau. And so with that, I'd just like to thank Joe. Tēnā koe, Joe. Thank you for today.
Kia ora, Mana.
Once again for the museum and all the staff and John and your team and the Auckland branch of the Royal Society Te Aoparanga for hosting us and for inviting us to talk today. And with that, I'm going to pass back over to John to do the closing remarks. Thank you, John.
Kia ora, Moana. Thank you, Joe. Obviously, such an extensive longitudinal study comes up with a lot of data, and I thank you both for guiding us through the considerations that we have to think about in the context of the results of this data. There's obviously a lot to think about, and certainly your website and the longitudinal study, which will be published on it as well, no doubt, will provide us with more information for us to go away and read about and think about it and inform us more for our vote at the end of the year. So thank you very much, both of you, for participating in this way. And thank you very much for our online audience and people who turned up in person on this horrible night in Auckland. Thank you, Auckland Museum, for the use of this wonderful auditorium. It's a great space for us to have a safe debate and talk about issues that are very important to us as a community. And we really appreciate the Auckland Museum for allowing us to utilise the space in the way that they have, and for all your staff looking after us as well. So please drive safely tonight, and good luck with your voting at the end of the year. Thank you.